Welcome everyone to today's webinar, a COVID-19 case study, lessons learned from New York's home-based care providers. I'm Home Healthcare News editor Bob Holly, and I'll be your moderator for this discussion. Right now, I'm going to take the next 5 minutes or so to go over some quick housekeeping items, introduce our amazing panelists for today, and then kind of lay the foundation for what's ahead. As for the housekeeping, first, please note that your lines have been muted for sound quality. Also, we will be sending out a recording of this webinar and a copy of the slides following the conclusion of the discussion. So if you miss anything, don't worry, we have you covered. I do want to emphasize, though, that the audio aspect of this webinar is really what's going to be most important. Yes, there are slides, but the real valuable information is going to come from the discussion and from the panelists themselves. And now for the speaker background. We're going to hear first from Roger Noyes. He's the Director of Communications of the Home Care Association of New York State. Roger's going to help us set the scene and share some perspective from his organization's home health and home care members. Also joining us today is Michael Bernstein and Dan Lowenstein, both of whom are from the Visiting Nurse Association of New York. Michael serves as VNSNY's EVP and Chief Administrative Officer, while Dan is VNSNY's Vice President of Government Affairs. Before we go any further, I do want to pause and just say thank you to Roger, Michael, and Dan for agreeing to participate in this webinar. They're in no way, shape, or form getting anything out of this on their end. They're really just doing it because they see value in sharing their experiences and lessons learned from the COVID-19 virus challenge that's going on right now in New York. So a huge thank you to them. So what's on the docket for today? We're going to approach this mostly in a Q&A form, first hearing from Roger and HCA-NYS, then shifting to Michael and Dan to learn more about VNSNY's coronavirus efforts. Toward the end, we're going to then bring everybody back together for more of a forward-looking group discussion. And next slide, please, Val. I promise we're going to go ahead and get started here in a second, but just a little bit more background, because I know some of you may be wondering, why is HHCN doing a dedicated webinar just on what's going on in New York? And how is that going to help me if I'm a home health provider in, Minnesota or Iowa? And the answer to that is we really wanted to host this webinar and have Roger, Dan, and Michael come on because New York is really the epicenter of this public health emergency right now. It's where we see the challenges clearest, and it's where home-based care providers really had to adapt the fastest. And this image here on your screen is as of April 8th, I believe. That's from Johns Hopkins coronavirus database, by the way. And then just on this next slide here, again, to help set the scene, these are just a couple of the comments that HHCN has heard over the past few weeks. I'll let you go ahead and read these on your own. I don't need to dictate them for you guys. So with that, we'll now move this into the setting the scene portion of the webinar, and I'll welcome Roger Noyes, again, Director of Communications to the Home Care Association of New York State. Roger, thanks for being here with us today.
Thanks, Bob. Great to be here.
So I guess to start, could you just give me some background, and our webinar attendees here, some background on your organization and its members?
Yeah, so we represent approximately 400 community-based providers, hospices, and managed long-term care plans, which are an insurance model for coverage of community-based care in New York State. And among our members, of course, is VNSNY, who is on this call. And we provide advocacy, education support, technical analysis to members in the community-based care field in New York State. And we've also been very active in emergency preparedness support for our members. As you see on this slide, I have our regular website, our main website, but we also have long established a emergency preparedness specific website, homecareprepare.org. And I point people to that site because it's become sort of a digest of what's been happening. We kind of have a running blog of news and updates on that site, as well as a COVID-19 resource page where we've attempted to post all of the regulatory waivers and flexibilities in a summary fashion, along with some links to the original sources of those relief measures and some guidance documents from various sources as well, that I think might be a helpful template for people to see sort of what rules and regulations have been relaxed in New York State. We know that there are federal changes that I'm sure everyone's aware of, but there are state-specific things that may be of relevance to other states and providers in other locales that you can take a look at and sort of see for possible measures to bring up the chain of command to your state's departments of health or other jurisdictions to gain relief.
All right, thank you, Roger. And just really quick here, I think just a second ago when I was introducing everybody, I misspoke. Dan and Michael are, of course, from the Visiting Nurse Service of New York, VNSNY. I think I misspoke on the organization there, so apologies to you guys. But Roger, going back to you, early on in this crisis, HCA NYS published a survey showing the needs and experiences of home care providers in your state. Can you tell me a little bit about why you decided to conduct the survey early on, and some of the key takeaways that you found?
Yeah, and I appreciate Home Healthcare News for providing coverage of that survey and its findings to really raise awareness about what's happening on the ground. So the reason we conducted the survey, which netted 300 responses in a matter of 48 hours, which was the fastest I've seen people respond to a survey request that we've done, and to realize that that was done at the same time as the consuming pressure of dealing with this crisis was happening, I just applaud people for being so responsive to it. But we're hearing anecdotally about things that were happening and sort of on an ad hoc basis from members. And I think we wanted to get a baseline understanding of what the pressure points were on a broad basis for purposes of advocacy and directing requests to the various jurisdictions for regulatory relief and other measures. And I think a lot of the data confirmed what we knew, but it gave a statistical context to be able to work from and to be able to point to, which was very important. And at the same time, our State Department of Health has been surveying providers on a daily basis, and they were asking some different questions. We had a chance to look at some of the questions they were asking. There was some overlap, but also some differences in the questions. But we didn't know at what time they were going to be sharing their results, or if they were going to share their results. And so we needed some contemporaneous information to be able to conduct our work on behalf of members for multiple advocacy reasons.
And we did cover some of those key takeaways, but what really stood out to you from the survey?
So Val, if you could go to the next slide, we have some items, a couple bullet points there. I think it was really important for us to know the extent to which patients were refusing services for fear of COVID-19 exposure. About half of agencies said this was happening. And I know for me personally, this got me thinking a lot about measures that providers should be taking to address this issue proactively. How they would be beefing up their education and outreach to patients and families, and trying to learn more about what discussions providers were having with patients, families, and staff in the field to address those issues. So that was very important to learn about. And also the survey results, I think, kind of prompted some other questions to ask members about, specifically on the bullet point number 2, we say 68% of agencies said they lack adequate access to PPE, which I know is among, if not the most important issue right now, it's among the top 3. And we want to know more eventually about, well, what were agencies doing to cope with those scarcity issues? What kinds of conservation measures were they employing? how were they coping with the lack of PPE access. And we found that agencies are being as resourceful as possible to really increase their contact with patients remotely, using remote monitoring and screening protocols, and communicating to their patients the screening protocols that they have in place to assure patients where possible of some of the safety issues that they may be concerned about. So those are some important findings from our survey. And then we also learned about a little bit more about the impact on patient caseload. Organizations, depending on the reason, we're having to transfer patients to other settings, and there's all sorts of hospital decompression issues and surge capacity issues for which this kind of information is important. So one thing I didn't mention on this slide, and I should have, was that we asked our providers, and actually this survey went out to all providers in New York State, not just our members. But we asked providers how many level 1 patients they have. And I can just, if I take a moment to describe that real quickly, what that means. In New York State, emergency preparedness requirements dictate that providers categorize their patient census according to levels 1, 2, or 3. And a level 1 patient is a patient whose care plan cannot be deviated from without a really severe harm to the patient's health. And these are very at-risk patients. And our survey found that of this sample of survey respondents, 14,000 patients in the community qualify as level 1 patients. And why that categorization is important is that in every effort being made to direct resources to the areas of greatest need, these types of protocols ensure that agencies have a good handle, or the best handle possible, on cases that cannot go without the care that is in the care plan. And other cases, say level 2 or level 3 patients, for which maybe a visit could be delayed, maybe telephonic or telehealth outreach would be suitable and appropriate, or where outreach to family members or informal caregivers could be of assistance as the workforce is overburdened and as other pressures are consuming organizations at this time.
Mm-hmm. Yeah, I mean, these findings right when they came out were so interesting to us. And again, it was fairly early on in the outbreak, but just to see the PPE challenge kind of quantified was really startling. You know, nearly 7 out of 10 lacking access to adequate PPE. Anecdotally, we've heard stories about providers sourcing PPE from tattoo parlors, trying to work with, you know, fashion designers to outlets like David's Bridal. So people really getting creative to figure out where they're going to get their PPE from. And now, Roger, I understand, so you've actually followed up on these initial findings and launched a second survey that provides, you know, an even clearer picture of what's going on.
Yeah, Val, go to the next slide. I think, sorry, as I mentioned, the first survey really helped jog some ideas for a second follow-up survey. So, for instance, one of the first survey findings was, well, how many agencies are experiencing issues with PPE access and scarcity? Our second survey presented an opportunity to dig a little further into that issue and find out, again, what agencies are doing to cope with that issue, some of the conservation strategies that they're employing, other measures like implementing a policy where if PPE is not available, then visits will be curtailed, either not accepting or admitting new patients for under certain circumstances. I mean, there are a range of circumstances under which providers are doing that, but we know that that's happening in the field out of concern for patients and caregivers alike, not wanting to put a provider's staff at risk, which is a major concern. So, you know, our first survey made clear that lack of PPE was an urgent need. The second survey provided some more detail about that. We also thought the time was right to learn more about some of the additional impacts on agencies, now that the crisis had settled in for some time, what agencies are forecasting in terms of financial impacts. I think it's very important that agencies should be tracking these financial impacts under as many measures or domains as they possibly can, especially as conversations are happening, and we know that there's been some announcements just recently about the announcements of funds for providers. And how many patients and staff are in isolation or screened positive for COVID-19, the impact on workforce capacity, and all of these issues really are vital for being able to advocate on behalf of providers for access to PPE, supportive regulatory waivers and policies that can really help providers cope and with the exposure issue in the field, and reduce exposure of staff and patients to these health risks.
Roger, when you mentioned the recent announcements related to finances, were you specifically talking about what CMS announced earlier this week, which I think the payments are actually going out today, that $30 billion infusion under the CARES Act going to Medicare certified providers of various types?
Yes, that's what I was referring to. And we're actually, once I'm done with this call, sending out an alert to our members about some of those details. But yeah, that is obviously of prime importance, financial relief. So we really need to examine what that looks like, and what's going to entail in the next round of funds that I understand are coming through as well.
Mm-hmm. Yeah, I had a conversation with Matt Wolf, an attorney from Parker Poe, yesterday actually about that $30 billion infusion, and he kind of couched financial relief in a really good way. It's that $30 billion. It's not going to be a ton of support, but it's a very important piece of the overall financial playbook that CMS is trying to develop. That's paired with the expansion of the Advanced and Accelerated Payments Program. That's paired with the small business loans that some providers might have access to under the CARES Act too. So I think all of these are definitely going to be important to come together to give some folks a vital lifeline moving forward.
And I think it's hard to assess the degree to which these funds are, collectively and under the different vehicles in which they're being provided, the degree to which they're going to be able to help cover losses and how much of those losses. So it remains to be seen for sure.
Roger, aside from the survey findings, just even anecdotally, what are you hearing from your members? What kinds of questions are you getting on a day-to-day basis? Anything, unusual or unexpected kind of stand out?
Yeah, I think most of the questions, certainly the biggest concern seems to be PPE access and how to facilitate that and navigate that issue. But many of the questions, I would say the vast majority of questions are really regulatory in nature. And I'd like to point out that the way, at least this has been the experience in New York State, is that regulatory waivers and allowances and flexibilities have really come fast and furious in a piecemeal fashion. It could be through executive orders from the governor's office, where there's been a cascade of them, and each executive order has somewhere buried in it some measure of relief that applies to our field. So you have to find what that is and sort of synthesize it all across various executive orders that have come out. There's, of course, the Department of Health communications that provide some of these regulatory waivers. So really getting a handle on this cascade of information and synthesizing it in a fashion that makes sense has been really pretty overwhelming. And so I think that's why a lot of the calls we're getting in questions are of that nature. As far as anything unusual, I think that of a crisis like of this size and of this scope, you're going to hear questions that are things that you didn't anticipate. You could never have anticipated, because you may not have anticipated something of this scale. I mean, obviously, providers have emergency preparedness plans, and they have an all hazards approach to them, and infection control, and all those things are part of that. But I don't think anybody realized the extent to which this was going to take hold at the way it did. So, we have questions on whether home health services can be provided in a hotel, for instance, because New York City is in the process of leasing thousands of rooms for patients to help with hospital decompression and issues like that. So, whether those kinds of services can be provided in those other settings. Lots of interesting questions about HIPAA, compliance questions when it comes to sort of the intersection between privacy and public health and surveillance, and how much of a patient's information can be shared on COVID-19 exposure or testing status, and to whom and under what conditions. And I don't have the answers to those right now, because that would be a whole other webinar. But those are among the things we're hearing that are interesting and that you might not have anticipated outside of this kind of event.
We're going to dive into this a little bit more deeply when we bring Dan from VNSNY on this webinar as well. But I'm just wondering what kinds. There's obviously been a lot going on, but what kinds of the regulatory waivers or guidance are providers getting in New York that might be helpful for other states to look at as policy solutions to deal with some of the COVID-19 fallout?
Yeah, so there's been a range of them, and I really encourage people to just look at our COVID-19 section of our homecareprepare.org site just to see a summary. I've tried to maintain a list of them by category because I thought that was the easiest way of sort of tackling it. But and I think a lot of the types of changes may really depend on state licensure and just what different states have for licensure rules and regulations. But among them are, delays, allowing delays in RN supervision visits or activities and procedures, flexibility on the timetable for initial visits, some record-keeping requirement flexibilities, and importantly, in our state Medicaid program, the state has given some wide latitude for telehealth or telephonic alternatives to services and billing allowances for doing so under the state Medicaid program in a way that we all know we are seeking from Medicare as well. One thing that I think, as we were discussing this in the planning of this webinar, is one of the issues is that in many ways home care can get overlooked in some of these directives and some of these activities. And while the state initially announced Medicaid flexibilities for telehealth to be done in a range of settings, it wasn't just exclusive to home care by any means. It was across virtually all settings. When you got down to the chart and the guidance, they had a whole chart of billing codes and billing procedures, and home care wasn't listed. So our work has constantly been a matter of going back to the state and saying, we appreciate this universal flexibility that is applying under Medicaid that's going to be of help. You need to include some billing codes for home care so that we know how to move forward on these flexibilities. And that this is the kind of activity that is happening across the board on a number of levels as we're managing this crisis.
All right, well, thank you very much, Roger. We're going to bring you back in a little bit, but I want to now turn to the Visiting Nurse Service of New York. And again, we have VNSNY EVP and Chief Administrative Officer Michael Bernstein and VNSNY Vice President of Government Affairs, Dan Lowenstein. Thank you guys both for taking time out of your very, very busy day to be with us.
You're welcome, Bob.
Thanks for having us.
Michael, I think we're going to direct these first questions toward you, and then Dan, bring you in for some regulatory clarity. Michael, I think my first question really is, just can you provide some background on your organization in terms of scale and services? I think most of us are probably pretty familiar with VNSNY, but just in case, could you kind of introduce yourself and your team?
Sure, I'm happy to do so. And again, thank you for having us both participate in this. By role, I am the Executive Vice President and Chief Administrative Officer of the Visiting Nurse Service of New York. And as that slide shows, and many of you know, we describe ourselves as both a provider and a health plan. And together serve over 44,000 people in New York. Downstate, what's interesting for us is the density of our area. We do almost all of our business in the 5 boroughs of New York and the surrounding counties. And on the provider side of our business, which is probably most relevant here, we have a certified home health agency under New York state regulations, a CHA as we refer to it. We have a hospice and palliative care business unit. We have something that we refer to as community mental health services, about 400 staff members who do all sorts of interventions related to behavioral health and psychosocial needs. And we have a division we call Partners in Care, which is our home health aid business, a workforce of approximately 9,000 home health aides, maybe often thought of as personal assistants, who go into the home and provide activities of daily living services for people that we serve, both people served by our certified home health agency, as well as members of one of our insurance plans, our managed long-term care plan. And we have a care management organization that also provides sort of longitudinal care and long-term kind of care management services to individuals. So that's a thumbnail about who we are. We have always had an emergency preparedness structure in place, and about 5 or 6 weeks ago, it became paramount. So Bob, that's kind of an overview of who we are.
So I think the long story short for me is there's very little that could go on in the home in terms of delivering care that VNSNY doesn't do already. So I really think that there's no better organization to have on right now than for this webinar. Michael, you know, as one of the key decision makers for VNSNY, what's a typical day look like for you right now during the public health emergency? What conversations are you having? What key information are you, constantly checking regularly?
Yeah, great question. So yes, I can answer that from what we call a leadership level, an executive level, and I will do so. And what I share with you all on this webinar is the day from a leadership perspective. It's not exactly the same day that our frontline clinical workers are experiencing. In many ways, their work is the same, but it is far more complex than it ever was because of COVID-19. Similarly, for our business staff, the people who are sending out bills or the people who are trying to chase documentation, they're doing the same work daily that they were doing before, but they're doing it against an entirely different backdrop, which I'm sure is obvious to everybody. It took us a little while, but we have a leadership cadence in place daily. Every morning at 8:15, we have a conference call or a Zoom call or a Microsoft Teams call, whichever, among the 6 EVPs and our CEO, and we review what transpired in the last 24 hours, and we look ahead as to what is going to happen during the day. And that call is COVID-19 specific. It is not when we're also trying to wedge in regular business decision-making and conversations. It leads up to our daily incident command conference call, which is held from 9 a.m. to 10 a.m. We originally thought it would be every other day, but it has proven necessary to be every single day. We had it, as I mentioned, an incident command structure. So we have 2 EVPs who split the duties in terms of being the incident commander and leading these calls. And we have about 45 people on the calls with a daily agenda. It's produced each evening and ready before 9 a.m. in the morning. And we run through department by department, again, an update. And it includes updates from human resources, updates from Dan Lowenstein's Government Affairs Department, who's on the phone with us, all operational updates from each of those business units, and so on. After that 10 a.m. call, right now, every one of us at either a leadership level or throughout the organization is online working from home answering emails, having conversations virtually, and meetings that are specifically related to COVID-19. When we're a fairly large organization, I'm not sure the size and scope of everybody on this call, but we have approximately 200 individuals that make up our highest level of leadership. And I can safely say that all 200 of them are engaged 90% in the management of our workforce and our city as it relates to COVID-19. We try to fit in other work when we can, but there's not a lot of time for that. I'll try to move a little bit more quickly here for you, Bob, but we talk about the safety of our staff. We said since day one that would be most important, and you tie that into the needs of securing PPE, and you can all imagine why that is a subject of conversation. We talk about our clinical protocols. We rely on the CDC and the Department of Health to give us guidance about how we can best care for COVID positive or presumptive positive, or those who have been discharged and are no longer symptomatic. So we talk about our clinical protocols. We maybe hit our stride now and understand exactly how to group patients into different sort of care buckets so we understand what we're doing. We talk about the impact with our referral partners. Obviously, we have a very overtaxed hospital system in New York, and we've been working to be in a position tied into PPE to be that off-ramp for hospitals. We talk about our financial needs. We're going to get into that a little bit when Dan Lowenstein speaks, but the way in which we can get reimbursement for the activities that we're undertaking and the incremental unintended expenses that we are incurring. We talk about our communications tactics, and if we have time, I'll go into that a little bit more deeply, but I would say to all of you on the call, we have found that effective communication is very challenging, but critically important. People sometimes in these environments hear what they want to hear, and that puts a premium on being precise, but also being understanding and empathetic when you try to communicate. We talk about human resources issues, all sorts of them, people who are calling out, people who are finding themselves symptomatic and what they need to do and how we're going to help them. We talk about compliance issues. That's major for all of our organizations and regulatory items. So those are the things that we talk about. The information we're looking for is data, ranges from how many people are calling out to what direction our referral volume is for any parts of our organization, to the inventory of PPE, and so on. So that's where we are, Bob.
Well, thank you for that great insight. It really does sound like communication is key. Those daily check-ins, sometimes twice a day, that are COVID-19 specific. And it sounds like that's communication within the leadership team, communication from the top down, communication from VNSNY to outside organizations and government entities as well. Putting that day-to-day picture aside for a second, looking back at the overall experience, what's the biggest pain point that you've experienced?
Well, I think it's probably shared by all of our industry-wide colleagues here on this webinar. And that would be that the biggest pain point is the clear lack of understanding by all sorts of decision makers about the role home care plays in our healthcare system. And Dan will say more about that. It's an industry-wide concern. It has plagued us in this industry, for forever, and it continues to do so. And it plays out in many ways. We'll talk more about this in a minute with Dan, but it plays out in how we can deliver telehealth and get reimbursed for it. It plays out in documentation, what needs to be signed, at least under New York State regulations, and what can be done about that. So I think our biggest pain point is that hospitals in our marketplace, they tend to be the big gorilla. They get a lot of the attention, not only in money, but in regulatory relief. And we seem to always be fighting hard for our place.
Mm-hmm. And from my perspective too, it seems like there's been a lot of misunderstanding or lack of awareness of the advanced capabilities of home health providers. Organizations like VNSNY especially, you're able to take care of pretty high acuity patients. So that's one thing that stood out to me, is maybe not getting that recognition for home health providers overall. What about on the PPE front? I'm guessing that's been a challenge, like Roger highlighted with that survey result.
Yeah, for sure. I mean, if you ask me to sort of rank our challenges, there are a number of them, some sort of internal and some of them perhaps external, like securing PPE. Absolutely a challenge. You know, I have learned over the last 4 weeks that PPE is a term we're going to all use to mean just about everything, but there are personal protective equipment that you wear, and there's other equipment and supplies that you need in order to effectively go into a home when you are providing care for someone who is COVID-19 positive. So you not only need your face shields and your gowns and your N95 masks and so on, but you need garbage bags in order for people to, when they're doffing that equipment, to have a place to put it. When you're doing a start of care, you need to make sure you have enough thermometers, you have enough blood pressure cuffs, you have other kinds of equipment that we didn't even necessarily think of initially when we were thinking of PPE. We have all had MRSA kits and other kinds of kits and so on and so forth, but the quantity of these items that we needed. So we have worked sort of both sides of the aisle, if you will, the public sourcing side and the private sourcing side. Dan can talk a little bit about the public sourcing side. On my end, I've been deeply involved in purchasing, and we've been buying all sorts of wearable PPE, surgical masks, and so on from, you know, sources and leads, most of whom we vet and believe are legit, but we're also moving fast, and we're concerned about getting burned, but we're in a position where if we don't provide this to our staff, we cannot ask our staff to go into homes. So I could go on for 2 hours on the PPE challenges. You know, another challenge that we have is that we're really not in a much stronger position than others to get our staff tested for COVID-19. Now that's broke better a little bit with CityMD, a large operation here in New York, agreeing to make our staff a priority for testing. But it's been a real dilemma for us and a real challenge to provide testing. We have instituted screening on the part of our workforce, take your own temperature and effectively self-identify by answering a series of questions. We do that with the patient population as well, but testing has been a challenge. And just to go back to that other theme, effective communication has been a challenge. I think we all know across the country, people are getting their information from so many sources, from the news, from the web, and so on. And often they hear what they want to hear, and often the information is contradictory. Sorting through that information, trying to present a transparent, honest understanding of where things are is a challenge. We joke, and maybe other people do, we could all be Dr. Fauci, but it's complicated information, and it is hard to communicate it to a diverse workforce. So those are some of our challenges.
And I mean, even just internally at Home Healthcare News, it is so tough to disseminate information because it changes on an hourly basis. Something that we publish at 3 p.m. may no longer be true at 4 o'clock. It's just a constantly evolving landscape. But Michael, kind of the most important question I wanted to ask you has to do with lessons learned thus far. What is VNSNY doing to solve or at least mitigate some of the challenges you highlighted? For example, I think I heard about VNSNY doing something that's particularly innovative when it comes to bringing PPE and other supplies into the home.
Well, I'm not exactly sure what you are referring to there, but we did just recently undertake an effort to use the U.S. Postal Service and mail surgical masks to 8,500 home health aides, so they didn't have to travel to get them, so that we could provide them with that. We have created what we call COVID-19 start of care kits and COVID-19 standard kits. And we assemble these kits in a central location, and then we get them to, in our case, our regional offices. And a COVID-19 starter kit is used by a clinician who is going to the home of a known COVID-19 positive patient or presumptive patient. And it includes enough PPE, wearable PPE for 5 encounters. And it includes some of those medical devices that you need in order to effectively start care. after that, if you will, or for other levels of care, not a start of care, but when you're doing other care and, for example, doing hospice care, you would get from one of our locations what we call a COVID-19 standard kit. The biggest difference is that it doesn't include some of those items like the thermometer or the blood pressure cuff or so on. And so we assemble those. We've had to get volunteers to be willing to come into physical space and create those. And so there are many lessons that we've learned over the month. I'll highlight two so that I don't repeat myself too much here. One of them is all hands on deck, getting people to step out of their day-to-day roles and agree to do other tasks is essential. We thought we had enough people to monitor our supply rooms and hand things out. We don't, because what we're doing now is not onesies and twosies, but lots and lots of PPE that has to be distributed. So looking at your workforce and seeing who can do jobs that are not, if you will, in their general scope of work, that's a lesson that we've learned. Another one that we learned, which I'm sure challenges all of us and will be handled in different ways, is getting out in front of minimizing in-person visits. If this epidemic, if this crisis, hasn't come to your location in full force yet, consider the ways in which you can stratify your patient population so that you can not have to make an in-person visit when it can be handled through a telephonic care or some other virtual care. Your staff is going to want that, particularly if you don't have enough PPE, and you're going to need to do it so that you do have staff free to make visits to people who are COVID positive. Dan may talk about the implications of that as it relates to reimbursement, but from an operational standpoint, don't wait too long to figure out a way in which you can minimize in-person visits, because it's going to come up on you really, really quickly. So I would encourage people to think about that.
Is there a certain role that's most often being redistributed to a different role? Like, for example, are you taking somebody from billing and maybe making them more of a supply chain logistics manager?
That's a great question. We're taking people from all sorts of business departments. We have a lot of different departments that we refer to as business operations. And yes, that's a perfect example. We have many members of our compliance department, and while they are doing compliance work, they are also involved in this work. We have our facilities guys. We happen to have 18 locations, right? So we have a number of people who are responsible for keeping our facilities up and running, but there's nobody in our facilities right now except for those who are sort of transient and that they come in to get PPE. So those folks have become assembly line workers assembling those COVID kits. And so have our executives at all levels. And not just to sort of, for a photo op, but because it's an all hands on deck kind of activity.
All right, well, thank you, Michael. I do want to move on because we do have a lot of ground here to cover on the regulatory front. Dan, sorry to keep you waiting. I
Not
think
at all.
in my discussion with you right now, I want to touch on three main areas as our webinar regulatory expert here: CMS moves, congressional action, and New York specific regulatory moves. We already touched on some of those items with Roger and Michael, but let's start with CMS. What actions has CMS taken that have been most meaningful, and why?
Okay, so thanks, Bob. First, I just want to thank, when it comes to Washington, I want to thank the really thoughtful, incredible, and persistent home care leadership that represents home care in Washington, and that's NOC and Leading Age, which now includes VNAA. We're members of both, and we're really proud to have them fighting for us. A few weeks ago, Marky Flannery, our CEO, and several other home care leaders, and NOC's Bill Dombey had a call with CMS Administrator Seema Verma to discuss what home health agencies needed to be effective partners. And they were very responsive on several fronts. There was flexibility in the homebound requirement, basically protecting patients from infection and illness by including COVID-19 positive and suspected, as well as those who are at risk of that in the homebound definition, allowing initial evaluation visits to be conducted remotely or through medical review, which is a big help in this environment, and then allowing PAs, clinical nurse specialists, NPs to order home care and establish the plan of care and certify and recertify. It's a huge and long fought win. Really important because it expands the supply of clinicians who can be connected to home care. And the best part of that is that it's not just for the pandemic, it's permanent. So those are really the things that I think are the biggest wins so far.
Is there something else that you would like to see coming from CMS? Because I know that this is something a lot of people have said, but more support on the telehealth front or the virtual care
yes.
front, maybe.
Oh yes, very much so. So there were telehealth. Just some context on that. I mean, and it's true. I mean, CMS was very generous in saying that home health agencies could supply telehealth. They could perform telehealth, but they didn't allow us to get reimbursed for it. Now, some context for this. CMS in that same rule allowed clinicians to bill Medicare for telehealth the same as they would in an in-person visit for 80 CPT codes. And but they're not allowing us to do this as an in-person visit, and that's a huge problem because, as Michael said, we are trying to do, whenever this is clinically appropriate, we have to minimize our in-person contact. I mean, it's just the right thing to do from a community spread point of view, as well as for our patients and our staff. And of
course, doing that also helps conserve PPE if you don't have to actually deliver those in-person visits.
Absolutely. So in a way, CMS is putting home health agencies in this untenable position of forfeiting adequate reimbursement in order to protect our staff and patients. And at the same time, we've got to deal with the regulatory burden of new documentation requirements around it. Now, they said they don't have the statutory authority for that, and that may be true, where we still think we should take a run at it. But really, we think that there's a fundamental misunderstanding that they have about how these visits work and what the value is. And these are not 5-minute phone calls. These can take as much time or more as an in-person visit, and they're resource intensive and they're meaningful interventions. The other thing that we'd like to see is some relief on the signed document constraints. As everybody knows, we have to have signed written orders and certifications in order to bill for services, and that's great if we can. It's great that we can now have NPPs be those signers, but in this environment, all clinicians are unavailable or increasingly unavailable to sign home care documents, even electronically. So we'd like to see some kind of flexibility so we can rely on documented verbal orders for eligibility certifications, and that would really expedite safe discharges and referrals to home care.
And kind of looking at that second bucket, so we talked a little bit right now about what CMS has done, what we would like to see from CMS moving forward. What about on Capitol Hill? What congressional actions have been particularly helpful to VNSNY? Is there something under the CARES Act, for instance, that you guys strongly support?
So I think the context here is that home health agencies really are struggling. I mean, admissions are way down. Elective procedures have stopped, so you're not seeing any admissions there. And you add the non-reimbursement for telehealth, the decrease in signed documents, cost of PPE, and other things, and you have a real financial crisis for this industry. And we very much appreciate the efforts of Congress, including our home state minority leader, Chuck Schumer, and Senator Gillibrand and the delegation. There were some good things in here. Lifting the sequester helps us with our Medicare revenue. The advanced Medicare payments will do that as well. And we just received some money from this tranche of this $100 billion healthcare fund today. So I mean, there are some good things here, but I think it's still just a start. I think we want to make sure that home health agencies, particularly those that are on the front lines of the response, are included in any new funding. Back to telehealth, Congress could have given CMS greater authority to act, but it didn't, and we think they need to be educated as well as CMS on this. Also, we just learned that there's some money for telehealth funds, $200 million in there, but it's not home health agencies and hospice are not eligible for that. So we're going to be back lobbying Congress in round 4. There's a number of things. I think certainly the telehealth reimbursement, PPE for our frontline staff, greater share of the $100 billion or new tranches of funding for home health agencies, and then revenue enhancements. Those might take a number of different forms, but for one thing, it'd be great to get a suspension of the 4.3%, the behavioral assumption cut that came through last year, since pretty much all behavioral assumptions, I think, are out the window right now.
Yeah, it's sometimes a little bit mind-blowing timing wise. Some health providers are dealing with this kind of unexpected event that nobody could see coming at this point in time, exactly when they're shifting to a completely different payment landscape with PDGM. So I definitely would see the value there as well. What about on the state level, Dan? What's going on in New York in terms of state orders and regulations?
So first of all, and kudos to HCA, and we have great representation from our Home Care Association, as well as Leading Age in the state, which also represents home health. And I'll talk a little bit about also the relationship with the hospital and their association too. COVID-19 hit at the same time that New York State was passing its budget, and it was a doozy. So, while we were going through the public health crisis, we had cratering revenue forecasts, and New York State was making some major Medicaid cuts and reforms, primarily impacting home-based long-term care. And added to that, the Capitol was shut down, so the traditional ways of lobbying were gone, and everybody's attention was split everywhere. But as folks know, we have Governor Coronavirus. And in addition to his very informative and reassuring press conferences, the Cuomo administration's, we think has been very responsive, overall on the executive orders, regulatory waivers, and guidances. And Roger said, and we agree. I mean, definitely home health was kind of the down in the queue. I think we're getting some relief now. They were certainly trying to kind of shore up the hospitals and make sure they had what they need. But they were, there were certainly some good things there. There was the billing for telehealth, certification and eligibility for long-term care services, being able to do that via, phone, not in person, things that really, would help with the, help avoid community spread were taken care of and are still being taken care of. I think they also, yeah, I mean, just like what we need. I mean, in addition to what we need, there's certainly, one of the things we got that, the hospitals got and certain providers got was liability, waivers for liability and record keeping. Home health agencies and hospices need that, as well as some of our category of workers there. And then also there is in our need to really kind of make sure that our patients and our members are safe in the home. We need to be able to modify care plans in a way that will protect them and protect our workers. And some of that is harder than it might seem. And so we want to work with the state on how we can really kind of take some of the lead there to provide, sufficient coverage for folks and not be like out of compliance.
Well, like I said before, lots of ground, but I think you just did a good job covering it pretty quickly. I want to bring Roger and Michael back into the fold here and kind of wrap with the final 10 minutes, kind of in a group discussion format. This is, I think, a thread that we've all touched on, but over the past several weeks, it really seems or feels like in-home care providers, whether we're talking about Medicare, Medicaid, or private pay, have kind of been left out of the picture to a certain extent, or have at least taken a back seat. Roger, any thoughts from your end on why that is and what needs to happen moving forward to get home-based care providers more in the conversation?
Yeah, I mean, that's been a long-standing issue, the visibility of home care. And I think part of it has to do with the actual practice setting to some extent, that you have caregivers, very inconspicuously providing care sort of behind the scenes in patients' homes, not in a very identifiable setting that you can point to in your community. And they're doing a lot of work that, when it's done right and done well, is averting crises. And so to show a crisis averted is often a difficult thing to point to. So it becomes it becomes a visibility issue that we're always confronting. So, and in a crisis makes it even worse, a crisis of this order. So I think it's really, really important that home care agencies be as connected as possible with, depending on your state, how the emergency management structure is. If it's your, the local jurisdictions, the state Department of Health or Department of Public Health, their emergency management and preparedness wing, and making sure that you're communicating all those issues. We talked earlier about how, the lack of understanding about the medical complexity of the patients that are receiving care at home. And our conversations with the New York City Department of Health, their directives on PPE have pretty much categorically excluded home care and hospice. We're getting some traction on that issue, but we've had to explain basically a set of circumstances that really demand PPE, because there are complex care that's being provided in the home, whether it's wound care, whether it's catheter care, feeding apparatus, all sorts of complex care procedures that are happening in the home care setting. And I don't think there's a great lack of awareness that that's even happening. So making sure that that is being well communicated and understood among all the stakeholders that are going to be making decisions to hopefully help providers in this crisis.
Michael or Dan, anything you'd like to add to that?
Hi, this is Dan. Yeah, one thing I think, picking up on Roger's point, I think it's really important that we recognize, that we and the hospitals and others are part of the same ecosystem. That's always been true. And I don't know, hospitals are what, like the elephant or the coral reef? I don't know. You can make your own analogy, but we do compete for resources, but we also rely on each other. And hospitals need beds for sick patients. Home health agencies are the off ramps. And if we have problems, they have problems. And to be clear, when we started getting PPE, we got PPE because the hospitals recognized that we couldn't take their patients until we got PPE. That set off alarm bells. That set off the hospitals and the hospital associations kind of like putting us in the mix to get what we needed. And we're kind of seeing the same thing on the policy side. There's I want to just make a plug that there's a letter circulating from your associations, the national, from NOC and the state associations, to get CMS to act on the telehealth requirement. And that was a result. That's hospitals and home care associations are signing on to this thing together. I think more of that kind of action, if we can see that our fate is tied together, that's all for the better.
But we only have a couple minutes left here, and I want to make sure that I end with this question. And this is for everybody here, Roger, Michael, and Dan. What's one key piece of advice or one key tip for everybody listening into this webinar right now to help them prepare for or to continue to survive through, if they're right in the middle of it already, the COVID-19 emergency as an in-home care provider? One thing that they could walk away from this webinar with. Michael, let's start with you.
Sure, and to all of the listeners, I do not mean this to sound gratuitous in the least, but my biggest piece of advice is make sure your lines of communication are open with your frontline staff. Listen to the people who are going into the homes, whether it's home care or hospice care or personal assistance, because we're asking them to do an unbelievable task. And if they don't feel that those lines of communications are open, and they don't feel that you as leadership are providing them with good information and good insight in an empathetic way, that's a recipe for problems. So I sincerely mean that. I think one of the biggest pieces of advice, maybe your organizations already do this well, but you can never do enough of it, is listen to the people out there in the field and do your best to answer their questions. Our CEO has weekly conference calls and answers questions in real time through an email distribution, not sort of spoken. And we have over 2,000 people asking our CEO questions because they want to hear and they want to express their perspective.
And Roger, what's one tip from you?
I think I want to sort of build on something Dan said, which is, I think it's really important, just looking at system-wide, ways of partnering with hospitals and in working on the systematic needs of the care population that you're serving, I think there are ways that you can be helpful to the hospitals, but also position your organization favorably in this environment to the extent possible. I mean, one interesting survey finding that we saw was that, agencies, home care agencies are very interested in having their RNs provision testing. And, if there are thousands of home care RNs in New York State, and just imagine what a powerful impact that would be in helping with our understanding of the progression of this disease. If they were armed with the testing capabilities and training to do that work and help us better understand this crisis, because that was one of the major impediments in our response to this, is the lack of testing capabilities, and home care could be a powerful resource in that regard.
And any other tip that you have besides those 2 points?
No, my colleagues covered it. All good.
All right, well, it does look like we are out of time for today. I just want to take this time to again thank Roger, Michael, and Dan one more time. Thank you so much for joining HHCN for this webinar. I know how crazy things are right now and how precious time is, so really appreciate it. And a big thank you to everyone who tuned into this discussion. We hope you got something valuable from this conversation, and we look forward to seeing you next time. Thanks, and have a great rest of your day.